Hi, Dr. Mary Ellen Chalmers, everyone.
Hi, everybody. Good morning. Good morning. So glad to be here. One other thing that I've completed in the last 4 years, is a master's at USC in oral medicine and orofacial pain. And it was an extraordinary educational experience. And it's from that education that today's presentation is going to be based on. So this presentation is going to be a 10,000-foot view from the orofacial pain perspective, and I'm not going to be speaking to you as an orofacial pain specialist, but rather as a restorative dentist with advanced training in pain. I embarked on the program at USC thinking that a good way for me to continue practicing well into my 70s, I'm not there yet, as I looked at my MD colleagues and DO colleagues, is they were using their brain and it wasn't as physical because, as I'm sure all of you know, whether you're practicing hygiene or restorative dentistry or surgery, it's a very physical profession and very demanding, and we rely heavily on our hands and eyes. And I thought, well, shoot, with a master's in orofacial pain as an orofacial pain specialist, I could continue to practice. Instead, what I found is that this material was extremely valuable for how I practice now. And, you know, pain, our patients judge us not really on the quality of the care we provide with respect to the contours of our crowns and how lovely our margins are, but they're really evaluating us and determining whether our treatment is successful based on, are they in pain? Does their bite feel right? And so to have more tools in my shed to be able to evaluate that pain really went a long way at the end of the day when, you know, you'd come back, you'd have a hard day, and there's that Post-it on your computer, you know, Mrs. So-and-so is still having pain, or her bite doesn't feel right, and that crown that you placed 2 months ago that you think is just fine. So that's the perspective that we're going to be talking about. Orofacial pain, of course, is now officially a specialty in dentistry, and it encompasses the diagnosis, the management, and the treatment of pain disorders of the jaw, the mouth, and the associated regions. So it's a general term. It covers any pain which is felt in the mouth and the jaws and the face. This diagram is jaw-dropping, I know. It was developed by Dr. Jeffrey Okeson, who's the current dean at the College of Dentistry at the University of Kentucky, and I took it from his book, which anybody who's interested in more pain education, it's a fabulous book. I think it's my Bible. It's Bell's Orofacial Pain. And it really illustrates how complicated the diagnosis and the treatment of orofacial pain is, and really why this really needed to become an official specialty. So to simplify, and particularly for the purpose of this presentation, we're going to lump that complicated diagram into 7 categories, from odontogenic sources, temporomandibular sources, jaw movement disorders. We're going to talk and be able to, and hopefully you'll have a better idea of how to differentiate between neurovascular pain, neuropathic pain. I call it the N's, neuritis, neuralgia, neuropathy. And then we'll touch briefly on headache disorders. So to set the stage, this was a patient that presented in my practice. She came in and she said, I've had pain 12 years right here. For 12 years, she's had pain and pointed right there. And I'm sure this sort of an x-ray is not foreign to those of you sitting in this room, because very often, patients have been everywhere and have had all sorts of treatments before they get to us. And for the newer practitioners in the room, if you haven't seen this yet, I promise you will. Because when they get to those of us who practice with this oral systemic whole body philosophy, they're desperate. She characterized the pain as continuous burning, dull and achy. Over the years, it had migrated to her ear, it had migrated down to her lower mandible. The treatment that she'd received was she had a root canal on 15, extracted. They did a root canal on 14, pain didn't go away. Pain at that point migrated to her ear and down to 19, where she had a root canal on 19, extracted. Pain didn't go away. And so at this point, 12 years later, one of the local naturopaths in town referred her to me, and we'll be talking about how we evaluated her and what we treated her after we talk about the different characteristics and how to begin to look at these situations. So let's start by talking about the trigeminal nerve. Through the course of I gained a tremendous amount of respect for the trigeminal nerve and just how complicated and how elaborate it is. So it emerges from the pons. It has a large sensory root that you can see that's in actually Meckel's cave. And then a smaller sensory root. It provides sensory information for the head, the face, the teeth, the mouth, the nasal cavity, and it also lines the dura. It's responsible for innervating the dura of the cranial cavity. Motor innervation. The motor innervation is along the mandibular branch, and it provides motor innervation to our masticatory muscles, as well as the tensor tympani, tensor veli palatini, the mylohyoid, and the anterior belly of the digastric. So from the trigeminal ganglion, these three sensory branches then are differentiated into the ophthalmic branch, the maxillary sensory branch, and the mandibular sensory branch. And understanding these branches and these areas is going to be important, particularly as we begin to assess patients for neurological issues such as shingles. So also involved when we're talking about orofacial pain is cranial nerve 7, the facial nerve. This also emerges from the pons, part of the brainstem. Cranial nerve 7, the facial nerve, innervates the muscles of facial expression, and as well it conveys the sense of taste to the anterior 2/3 of the tongue. It typically travels from the pons through the facial canal and the temporal bone, and it will exit at the stylomastoid formation, foramen. The facial nerve is the nerve that is typically affected when we're dealing with Bell's palsy. Bell's palsy, you're going to find, is typically attributed, about 50% of the time, it's going to be attributed to your herpes simplex 1 viruses. And another common syndrome, I actually had the misfortune of diagnosing it in my sister 2 weeks ago, is Ramsay-Hunt syndrome. Ramsay-Hunt is actually the shingles virus attacking the geniculate ganglion in the facial canal. The symptoms are going to be problems with musculofacial expression. She had the droop. She couldn't close her eye, but she also had severe pain in her ear with ear vesicles. And what's important, why is it important to diagnose these symptoms and to recognize them for what they are early is because they can create and contribute to some long-term nerve damage. So when we talk about the transmission of pain, the trigeminal nerve has cell bodies that are located in the Gasserian ganglion or the trigeminal ganglion. The afferent neurons, these are the neurons that travel from the source of pain, enter the brainstem and they synapse with second-order neurons which are located in the trigeminal spinal tract nucleus. They synapse down in the nucleus caudalis. The pain sensations are then carried up through the thalamus into the cortex where the body then decides what to do. So there is normal sensitization that follows an injury that is intended to prevent additional harm. The sensitization results when we have an injury. It keeps us from further injuring the area. And normal sensitization, meaning tenderness in the area where the injury is actually a helpful process. However, what's important for us to know is that when the pain persists for longer periods of time, there can be changes in the local nerve and brain biochemistry. And these nerve changes are usually characterized as peripheral sensitization, central sensitization, and sympathetic sensitization. So peripheral sensitization is the first change. The damaged or chemically injured nerve is upregulates, and as a result of the length of time that these pain signals have been present, it has a tendency to pull in more mast cells, more inflammatory cells, and you see a dramatic increase in the amount of neurochemicals. These neurochemicals then involve nerves that are located peripherally to it, so that the patient's experience and description of the pain is going to spread. It makes pulpal and alveolar nerves much more responsive to non-painful stimuli, and sometimes will even make these nerves fire spontaneously. Central sensitization is going to be the second change. Peripheral sensitization happens within weeks to months. Central sensitization happens usually at about 6 weeks to several months. And when the peripheral nerve exhibits this excessive and ongoing firing, it overwhelms the trigeminal nucleus in the brainstem with too many signals. It then sends more signals up to the cortex, and as a result of this, the way in which the brain addresses that pain and manages that pain becomes overwhelmed. And so what we see is descriptors such as patients will have pain called allodynia. Allodynia is a type of pain where we're lightly touching a cheek and that the patient can experience pain. So it's pain that patients are experiencing from stimuli that otherwise wouldn't be painful. Another common form of expression of central pain is hyperalgesia. Hyperalgesia is when you exert a painful stimuli, but the magnitude of the pain they feel is far greater than what one would expect from just a simple push or a simple prick. And it's important to recognize these because often when our patients have been in pain for a long period of time, these are common findings. The third change, this is not something I think that we're going to see very often in our practice. Third change is when the peripheral nerve becomes responsive to our adrenergic molecules, our epinephrine and norepinephrine. And it then goes on to upregulate our sympathetic nervous system. You're still going to see hyperalgesia and allodynia. The central sensitization symptoms are still going to persist in these patients. The pain is then associated with changes in the skin blood flow, edema, or you'll see abnormal sweating. These are usually required symptoms for a diagnosis of sympathetic sensitization. These patients are often going to be diagnosed with something called complex regional pain syndrome, and these patients do require a multidisciplinary approach and often really aren't going to be treated in our offices. So we're going to talk about specific presentations of orofacial pain and how to identify them with an exam. So when I do my exam, the first thing I'm going to identify is masticatory muscle disorders. And it's important to know that muscle pain can present in 3 distinct ways. It can be local myalgia, meaning that when you palpate that muscle, it's painful, but the pain doesn't travel, it doesn't go anywhere. We often ask the patient to characterize it as mild, moderate, or severe. The second thing that we'll find is we will find myofascial pain. In patients with myofascial pain, you're going to find those taut bands, you know, those ropey muscles that you feel when you're palpating the muscles. We're going to ask the patient if the pain will spread. And then often what we'll find with myofascial pain is that we'll find that it refers. So it's important to distinguish the two with the manual exam because the spreading and the referral that happens with myofascial pain can explain the pain that we find in other areas of the head and neck. Another fun fact is that fibromyalgia is actually a centrally mediated representation of pain. So when patients come in saying that they have fibromyalgia, you know that there have already been chemical changes in the brain that have affected even though the pain may be related to a certain area, they're feeling that pain all over their body. So how the patient describes their pain is going to give us clues as to whether the pain is from their muscle or whether the pain is from their nerve. So the common muscle pain descriptors are dull, aching, cramping. When the patient has pain, that pain is going to be worse with function. If you ask them to open or close, they'll say the pain gets worse with chewing. It's important to know that over time, myalgia can and often does progress to myofascial pain. And it's important when we have patients with myofascial pain that we also test for these symptoms of hyperalgesia and allodynia. Again, hyperalgesia is, I have a little wheel, that I'll run along these areas, and they experience a heightened sense of pain that you wouldn't expect from the pressure that I was using. And of course, again, allodynia is just lightly brushing their cheek and asking them if they feel pain. So when performing a manual muscle exam, we're trying to find and identify the taut bands and the trigger points. And one of the important things I learned was that the force that we want to use when we examine these muscles is actually much more than one would think. There's a great gauge. I mean, when we were at USC, they were training us with the gauge. And the amount of force that you want to use is a force of 2 kilograms for about 2 seconds. And it's interesting to see that exactly how much force that is. And what I found for myself is I wasn't using anywhere near enough force when I was examining my patients. Important questions when we find a trigger point is, does the pain travel and to where? The diagram on the left is, of course, Trevelyan-Simon's chart with referral patterns for orofacial pain. It's often important to know, for example, that the muscles, the trigger points in the sternocleidomastoid, can refer to the temporal area. It can refer to the upper maxilla. And I have a chart that I keep in both operatories just as a reminder when I find these areas and when patients are describing where their pain is located, to think and to make sure that I evaluate and that this pain isn't referred from elsewhere. Let me go back. So conventional treatment for myofascial issues are home care, always home care. We'll teach them something called an end stretch, warm, moist, heat, avoidance protocols, anti-inflammatories, and of course, occlusal stabilization splint. And what we'll be talking about towards the latter end of this presentation is some of the integrative ways that I think can make a difference. In the domain of orofacial pain, these protocols, the conventional treatments, are considered successful when patients experience about a 50% relief. They consider that to be a success. The medications that are anti-inflammatories are tolerated well. However, when we're talking about central pain and peripheral sensitization, often the drugs that are used are anticonvulsants and antidepressants, typically your SNRIs. And with particularly the patients I think that we see in our practice, it's very poorly tolerated. And so being able to integrate some of these other modalities is important. But we do a lot of occlusal stabilization splints, particularly when we find taut bands and trigger points, because they do help. Joints, the next thing we're going to evaluate is the joint. And the joint pain is going to start as arthralgia and often will then progress to arthritis. And it's important for us to differentiate whether we're dealing with an osteoarthritic joint or whether we're dealing with a rheumatoid arthritis. It's easy to palpate. You palpate the joint preauricularly and within the ear canal, and you simply ask, is there any pain as they open and close? Of course, we've got disc displacements, we have hyper and hypermobility of the joints, and with respect to clicking and disc displacement, typically what we'll advise for those patients are our joint avoidance protocols. No hamburgers, minimizing and keeping their mouths open. The current line of thought, at least we learned from USC, was that we're not going to be able to recapture these discs. That's typically not the way we go, and what we're doing is we're just advising the patient that with a disc you always have, with a disc that clicks, you always have the opportunity for that disc to become further displaced either in front of the condyle or behind the condyle, and then of course that's going to require more advanced treatment. Typically the conventional treatment in addition to an occlusal stabilization splint is our anti-inflammatories. So an important finding in our chronic headaches patients is the comorbidity of TMJ and masticatory muscle symptoms. So for those of you who are asking about headaches on your health history, whether it's a chronic tension headache or a migraine headache, it's very important with these patients that we screen them for myalgia and myofascial issues. The occlusal stabilization splint, according to the scientific literature, is actually very, very effective with headache patients, and anybody who comes in as a chronic headache patient gets screened for this. Another important problem to identify is low vitamin D. Case-controlled studies published by the Journal of the American Headache Society in 2017 and 2018 found an association with low vitamin D in both chronic migraine and tension headache. The 2018 paper found that patients with vitamin D levels of 50 to 100 nanograms per ml had over 80% fewer migraines than patients with vitamin D levels below 20. So when we can't identify an odontogenic cause, meaning a cause related to a patient's tooth for our pain, it's important that we understand the differences between the various types of neurogenic pain and how to separate them diagnostically. Last month I spoke about pain and treatment of pain at the frequency-specific microcurrent. And what I was hearing from the practitioners there is that everybody was treating trigeminal neuralgia. That's the common, well, I've been taking care of a patient with trigeminal neuralgia. And when you push them and you ask them to become more specific about the symptoms, we're then able to stratify, is it a neuritis? Is it truly a neuralgia? Is it a neuritis? Is it a neuroma? Or in fact, are we dealing with a neuropathy? And it's important to identify that because our treatment is going to be different for each of these things that I call the ends. So trigeminal neuralgia are characterized by electric-like sharp stabbing pains that are going to last anywhere from seconds to minutes. Typically, the patient will describe on a VAS scale, they'll describe the intensity of the pain as an 8 to a 10 over 10. It's categorized into trigeminal neuralgia. There's a primary trigeminal neuralgia, and what the primary form of trigeminal neuralgia is, it's a vascular compression of the nerve and damage to the nerve sheath. So the cerebral artery sits on the trigeminal nerve as it emerges from the trigeminal ganglion deep in the brain. And some patients, the typical first line of treatment is carbamazepine, an anticonvulsant. Some patients are actually treated with surgery. A secondary form of trigeminal neuralgia is from demyelinization of the nerve sheath, as you would find in multiple sclerosis or tumors in the brain. And then we have a third type, which is called idiopathic trigeminal neuralgias. And those are the ones where we may have some influence. I have I was given a gift a couple weeks ago. I had a patient come in with idiopathic trigeminal neuralgia, and fortunately she'd already been to a neurologist. She'd had her MRI, she'd had her MRA, and had a complete workup. We'd eliminated that it wasn't primary trigeminal neuralgia, there was no nerve compression. And that she didn't have multiple sclerosis. And so from there, we went on to evaluate her occlusal forces, and I'm going to talk more about how we do that when I talk about digital occlusal analysis. So it's important to identify the contributing factors. Before you jump right in with a patient who's complaining, if you happen to be the first line of defense, the first person that patient experiencing trigeminal neuralgia sees, it's important that we get them to important that we get them to have that MRI to rule out whether there are more serious things going on. So classically, a paper published back in 1987 found that 8.4% of patients had structural pathology on an MRI, and about 10% had tumors, meaning meningioma, acoustic neuroma. So again, we absolutely positively have to make sure that with these patients, that we cover our butt, frankly, and make sure that we've ruled out all these more important and more significantly dangerous reasons for trigeminal neuralgia. But again, we're talking about these sharp, sudden, stabbing electric pains that are of short duration. Sometimes they can be triggered by wind. The patient will often know what triggers these symptoms, but that is what we're talking about when we're talking about trigeminal neuralgia. So let's describe neuritis. Neuritis is a continuous, unremitting, burning pain. And we want to think it's inflammation. It's inflammation to the nerve. For hygienists in the room, my hygienist has identified a type of neuritis that happens when a patient is sensitive to the nickel in their appliances. Do you have those patients that can't tolerate having their teeth cleaned because there's so much nerve pain? It burns and it hurts the entire time they're in there. What she found was that by switching to titanium-coated instruments and eliminating the exposure of the nickel, the stainless steel appliances, we've been able to have these patients be a lot more comfortable. A sinus inflammation is going to be an example of a neuritis, right? Again, the descriptors that we're going to be looking for are continuous, unremitting, burning. Often these neuritises are viral induced. Again, the Ramsay-Hunt syndrome that I had the misfortune to have to diagnose last week. Post-anesthetic dysesthesia. Again, it's the tingling, the aching. It's when we give that inferior alveolar nerve injection and we can damage the inferior alveolar nerve. And implant-induced nerve compression. Infection, so we need to think viral infection with some of these patients. And it's important, we often with these patients will use frequency-specific microcurrent to treat for neural inflammation, but we're always ruling out infection first. This is an important thing that I wanted to include because with the advent of the COVID vaccine, we have seen 4 instances of this in my practice. There's an increased susceptibility to shingles and to herpes simplex 1 expression after dental treatment. I had a patient that called me up 2 days after treatment. She was experiencing pain starting at her ear and going to her eye. And we had treated, we'd done a simple filling on her upper second molar. When I did a literature review, what we found is that this is in fact much more prevalent as a result of the COVID vaccine. What they're attributing it to is a depression in immune response. The most Often the cervical, the trigeminal V1 is one of the more common areas where we'll see this. And it's important to recognize the symptoms, again, this burning, this tingling, because those are the patients that we're going to want to place on valacyclovir ASAP so that we're able to mitigate the symptoms and shut it down right away. And we, in fact, were able to do that. I told her I thought that that it was shingles. I didn't think, based on her descriptors, I didn't think it was HSV1. Her comment to me was, well, I've never had chickenpox, it can't be shingles. I referred her to her MD at Kaiser. They did a viral titer, and in fact, she had had chickenpox, and her shingles viral titers were elevated. So being aware that this is something that we're going to be seeing as patients, if they should continue to boost, it's important to know. Another paper from the literature, these are photos of two patients with the herpes zoster virus, shingles, following a COVID-19 vaccination. And you know, the point that the authors made with this particular paper was that we need to be aware of this because it could have been misdiagnosed simply as a stomatitis or oral herpes. And it's important, again, as I said, the typical, what we prescribe is we prescribe a gram of valacyclovir TID for those patients for a period of a minimum of 10 days. The pathophysiology is related back to the sinus, and you can see, I don't know if, yeah, well, you can see how the virus in the ganglion can then manifest with lesions in the mouth. So let's go on, let's talk about neuromas. Neuromas are growths, so tumors of nerve tissue along the nerve fibers or the myelin sheaths. A neuroma can be a true tumor, such as a neurofibroma, an acoustic neuroma. But more often what we're going to see is a traumatic neuroma. And a traumatic neuroma is a traumatic bundle of nerve fibers that form at the end of a severed nerve. We're going to see that with a third molar extraction or often a mandibular molar extraction. The symptoms, the first symptom is going to be paresthesia or complete anesthesia of the area that the nerve, the transected nerve, is innervated. Over time, the neural fibers and the connective tissues are going to form a nodule that's very, very painful. And when it's compressed either with palpation or with function and movement, there'll be an electric sharp stabbing pain. These pains are often continuous, and they're triggered again by, it could be triggered by chewing or any kind of physical contact. These symptoms are going to develop over time, so we know we're dealing with a neuroma if they're preceded by complete anesthesia or paresthesia. Conventional treatment for these patients is very, very difficult, and in my practice, when we at the anesthesia stage, the paresthesia stage, we get right on them with frequency-specific microcurrent. So the hallmark of neuropathies, moving on to talk about neuropathies. Neuropathies are continuous pain, and the descriptors are going to be tingling, burning, aching. All neuropathies have a central pain component. And I want to talk a little bit about burning mouth, specific to burning mouth and tongue. Sometimes with these patients, what we're going to see is small nerve atrophy, that the nerve fibers in the tongue atrophy, and that we see a decrease in nerve density that contribute to burning mouth syndrome. What I've found in my practice is that the diagnosis of the causes for burning mouth syndrome are actually, it's a diagnosis of attrition. You know, we go down, we look for food allergies, we look for nutrient deficiencies. We have a whole protocol, and I could talk for an entire couple of hours on that, not time today. Talking about other neuropathies, I think the most vexing for us is atypical odontalgia, and this is a term that I hadn't heard before. This is when we have continuous burning, aching pain, and it often involves the inferior alveolar nerve. Another form of it, of course, is phantom tooth pain, but this is when the pain persists after a patient has had a root canal or an extraction. And it's important to recognize that this is actually a expression of peripheral or central sensitization, and that the answer is not to do another root canal. And so that's the beauty of understanding these particular modalities and how pain is expressed, because for a lot of our colleagues, when they hear pain, you know, all they've got is a hammer, and so everything's a nail. And this is why we see so many of the patients that present in our office having had root canal after root canal after root canal, and not recognizing that we're dealing with either L-typical odontalgia or sympathetically sympathetically maintained pain. I just want to talk for a minute about Nico lesions. And I think it just goes without saying that we always need to consider that these patients are going to have peripheral or central sensitization. It's described as neuralgia-inducing cavitational osteonecrosis, and I think I might substitute the word neuropathy-inducing. Because of the fact that these patients have often been in pain for a long period of time. And so identifying the peripheral, the central, or the sympathetic components and treating appropriately, I think, are going to make these patients feel better and should be identified pre-surgically. So we'll go through these history exams quick. The most important thing for me is our pain history. I want to know when the pain began, and I spend a lot of time with them making sure that I get a good description of the descriptors, because of the descriptors, meaning the intensity, the quality, the duration, the frequency, how does it change over time, what makes it better, what makes it worse, is going to go a long way in helping me identify why these patients are in pain. Again, descriptors, musculoskeletal pain is aching, pressure, tight, stiff. It's going to get worse with function. Neurovascular pain, when we have patients with neurovascular pain, often these are migraine patients, but their descriptors are going to be different. They're going to talk about throbbing, pounding, rhythmic. It's going to get worse with Valsalva maneuvers, bending over, physical activity. Again, oftentimes our migraine patients are sensitive to light, sound, nausea, vomiting. And again, it's important with any migraine or headache patient that we also identify whether they've got myofascial issues. Neuropathic pains are going to be very different. They're going to be itchy, they're going to be burning, they're going to be electric shock-like. Often with our neuropathic patients are these central sensitization symptoms of hyperalgesia and allodynia. In terms of imaging, CBCT, you know, you can use a pano for screening, but for patients with chronic pain, and I know I'm preaching to the choir here, CBCT is really the only way to go. MRIs are useful if you suspect soft tissue damage within the temporomandibular joint. And again, this particular information is not news to anybody here. So occasionally I'm going to perform a full cranial nerve exam, but as a restorative dentist, I don't do that very often. I'll do it only if the patient's symptoms indicate what they need. I obviously don't have time to go through the whole exam here. I would direct you to YouTube. My favorite guy on YouTube is the Ninja Nerd. He does a fabulous cranial nerve exam, and I think it would be a great resource. But what I do often is this corneal or blink reflex. It's a quick way to screen for problems with cranial nerve 5 and cranial nerve 7, because most often those are the nerves that we're dealing with. And all it is you have the patient look to one side, you take your Q-tip, you make that light thread, and you try to stroke it along the cornea. The normal response is that both eyes are going to blink. Our sensory innervation to this area is from cranial nerve 5, and our motor innervation is from cranial nerve 7. If we have one eye blink or neither eye blinks, it's then going to help us to identify which nerve that we may be dealing with respect to problems. So intraoral pain disorders, you know, this is our wheelhouse. We're all pretty expert, I think, in diagnosing pulpitis, periodontal and gingival abscesses. I want to jump to our last two, the oral mucosal pain, burning mouth, as I said. That's such a complicated thing to diagnose with respect to what is the root cause. Atypical odontalgia and occlusal dysesthesia. And again, these are manifestations of peripheral and central sensitization pain. We've talked about atypical odontalgia. What we haven't talked about is occlusal dysesthesia. Occlusal dysesthesia is a centrally mediated symptom where the patient says, my bite's not right. My bite's not right. My bite's not right. And I mean, how many times have we heard that? And we know the bite is right. And it's very, very difficult to to convince these patients that that the bite is fine. What I have used in my practice is digital occlusion, and we'll talk about that in a minute. But it's important to know with these patients, stand your ground. These patients have changes within the brain. You could refer them at that point to an orofacial pain specialist if they're going to go the medication route. And oftentimes these patients do have psychiatric issues that require some cognitive behavioral therapy. So know that this is a syndrome that exists. It actually has an ICD-10 code, and that what we're dealing with is a neurological issue with these particular patients. This tree, this odontogenic tree, I think is helpful for identifying those patients where we're dealing with true odontogenic pain and patients who are not. The tools in my practice are the cold test that we use for the tooth. If a patient complains about pain, we use a cold test and we check for fracture. The other thing we do quite frequently is we administer local anesthesia. And when the patient doesn't respond as I would expect, then I'm going to think that we're looking at some sort of central or peripheral sensitization. I had a patient that came in, virgin teeth, and she was certain that tooth number 15 was going bad and needed a root canal or needed to come out. And it was a simple test. We tested all of her teeth with cold. And what I took a look at is I could see that there was an impacted third molar, tooth number 16, when she'd been resisting. For years, she'd been resisting a CBCT. When I went up and gave just an infiltration over that area, all of her pain went away. We were then able to convince her to get a CBCT, where we found this massive dentigerous cyst that had actually displaced the posterior wall of the sinus. And that was in fact what was provoking her pain. So the next 5 slides, I'm going to just skip ahead because I really want to spend some time on our integrative treatments, because that's really where I feel I can add the most benefit and the most information to the conversation based on my background. But they're going to be helpful, I think, if you take a look at them for distinguishing atypical odontalgia with pulpal pain, myofascial pain, and trigeminal neuralgia. Particularly with pulpal pain, again, pulpal pain is going to oscillate. With atypical odontalgia, it's going to be constant. Myofascial pain, all right, with atypical odontalgia, the pain's going to be relegated to a tooth or a tooth site. And with myofascial pain, of course, we can identify that easily with muscle and muscle palpation. Trigeminal neuralgia, again, we talked about our pain descriptors for trigeminal neuralgia: unilateral, sharp, sudden, electric, stabbing. And it only lasts for a short period of time, where with atypical odontalgia, we're going to be talking about pain that's dull and continuous. So my favorite part, integrative strategies. This was another reason that I took the USC course. You know, I really didn't do much pain treatment. And if I couldn't get a patient well prior to taking this program, if I couldn't get a patient well with a night guard, they went on. I have a fabulous diplomat, orofacial pain specialist down in Marin, and in a red hot minute, they were down there because simply didn't have time, because these patients often take a lot of time until you fundamentally understand and then can screen them out faster. And it was actually she who suggested, because remember, as I said, traditional orofacial pain specialists, they're using anticonvulsants, they're using antidepressant medications, more typically SNRIs than SSRIs. We're using splints, they're using physical therapy. But with a lot of these chronic pain patients, if they get a 50% reduction in pain, they're considering that to be a success. And it was Jennifer Buchanan is who I refer to in Marin. And she said, I think some of what you know may actually begin to help these patients. And so all of these are treatment strategies that I use in the office. Acupuncture, cranial manipulation, I actually opt for that in lieu of standard physical therapy. But, functional medicine, most of you, for those of you who have heard me speak before, you know my background. I'm a huge believer in functional medicine. It was functional medicine that made that oral systemic connection for me back in 2009, 2010, when I started my certification process with the Institute for Functional Medicine. Having a healthy, stable state, addressing diet and lifestyle is well within our purview. Nutrition is something that we should have a conversation with all these patients. With respect to obesity and BMI, one of the interesting things that I noted as part of this program, we studied 240 orofacial pain cases over a period of 2 years. And what was significant for me was that in the neighborhood of 60 to 70% of these patients all had a BMI of 28 or 30 or higher. And within the realm of functional medicine, fat can be an inflammatory organ. So it's important to educate these patients to realize that if they want to bring down their overall inflammatory load, that addressing diet, exercise, sleep. I have an Oura ring. The Oura ring I find to be phenomenal. All it does is it brings mindfulness to our sleep. And it's amazing how much it can improve just by being mindful. So functional medicine is our first go-to. We often start these chronic pain patients on an elimination diet. Oftentimes, remember, for those with respect, from a simple intraoral exam, we can see the signs for gluten sensitivity and different food allergies. So functional medicine is the first and foremost go-to when we're dealing with our chronic pain patients. Medical foods. Medical foods is another tool that we have in our shed. I learned, I can be specific as to, if you ask during Q&A, there's a specific brand that I use that that we don't talk about in these presentations. But Jack Kornberg, who was a general surgeon, used to place patients on medical foods that had a special kind of curcumin, a highly bioavailable curcumin, prior to surgery. And particularly with our NICO patients who are going in to have surgery, and they've got symptoms of allodynia and hyperalgesia. We're concerned, number one, that they're not going to be able to chew, but by putting them on these shakes, these medical foods prior to surgery, we're down-regulating their pain pathways so that when they come out of surgery, they're going to respond better, their pain levels are going to go down faster, and they're going to heal better because they're going to be, the other nutrients that are there are going to be tremendously beneficial for healing. Vitamin D. We talked a little bit about vitamin D and headache. With respect to pain, there's direct anti-inflammatory effects. Vitamin D suppresses pro-inflammatory cytokines and has direct inhibition on NF-kappa B. The one thing that's important with vitamin D is that it's affected by patients' genetic SNPs, and that we may have to work harder in some patients to get these levels optimal. Remember, these optimal levels are 50 to 80 nanograms per ml, and genetic SNPs often play a significant role in whether we can get the patient in that range. Omega-3 fatty acids. This is another tool we have. Long history in the scientific literature, the use of omega-3 fatty acids and decreased pain. Goes way back to 2007 where a meta-analysis was performed on the efficacy and use of omega-3 fatty acids to a recent 2022 paper published in the Journal of Clinical Nutrition. In addition to supplementation, there are a number of dietary sources, and the studies seem to indicate that with respect to essential fatty acids, it's dose dependent. We're talking about 2 to 4 grams. Beneficial effects of magnesium therapy. Magnesium therapy is especially helpful in neuropathic pain, including post-herpetic neuralgia, chemotherapy-induced peripheral neuropathy. In addition, magnesium treatment has been reported in the literature to alleviate fibromyalgia, headaches, and acute migraine attacks. The mechanism that they think here is that it inhibits the calcium ions, right? A lot of pain is mediated by our calcium ion channels. It inhibits the calcium ions from entering the cells by blocking those NDMA receptors, and it results in having an analgesic effect. This analgesic effect is related to the prevention. It will actually help prevent central sensitization caused by peripheral tissue injury and peripheral sensitization. So the magnesium supplements that I typically go to in my office are magnesium threonate. This is the only form of magnesium to cross the blood-brain barrier. We start there. We start there with having them take the maximum dose. And then I supplement in, depending upon the patient's individual needs, I'll supplement in magnesium glycinate or magnesium malate, and they take those to bowel tolerance. So the magnesium threonate, we rarely see any reaction from the bowel. We start by having them add 1 tab of magnesium, either glycinate or malate, at night. Then they'll add a second tab in the morning, and then they'll add another one at night. But again, it's all to bowel tolerance. Zinc deficiency is implicated in peripheral neuropathy as well. In addition, zinc is going to be important in taste and smell alterations. Particularly the official terms for that are dysgeusia and hypogeusia, I can never pronounce them. Anyway. But we keep a bottle of this in the office, and the 1 to 2 teaspoons taken orally. If the patient doesn't taste the zinc, then they've got a zinc deficiency. And we administered this during their initial exam. Other indicators are going to be the lines on the fingernails. Part of our exam should always include looking at a patient's hands. So I've referenced this a couple of times. This is digital occlusal evaluation. This has been a tool that I've utilized in my office since 2010. I can't imagine how I would practice without it. So it's going to measure our chewing forces in time increments of 1/100 of a second and force values of 1/100 of an inch. And the goal is to identify hyperactive, overly engaging contexts during exclusive movements. So DTR, disclusion time reduction, there's actually a class and a program that talks about this. They pair this with an EMG. I haven't taken that class yet. I will. I find that I'm finding that with a really fine, well-tuned manual exam, I don't know that I need an EMG to find those points. You know, you can find those trigger points, you can find those taut bands, and if they then, I had a patient that came in, she was a long-term patient, she had had a history of neurological issues. I think Neil Nathan is a name that many of you in this room will know. She was a patient of Neil's who treated her for her neurological issues that happened following the birth of her third child. But she was fine. She'd been well, and she came in for her hygiene exam, and she said, "Oh man, I've been having these headache attacks." And I said, "Describe it." And what she was describing was an atypical trigeminal neuralgia. Well, having gone to YouTube and watched the videos from the DTR group, what I did was I performed I did a T-scan, and what I found is if you look at the reading on the right, you can see that there was a working interference present on the buccal cusp of tooth number 14. 15 had been extracted years ago because of a failed root canal with an instrument left in and a massive infection. So what would happen is she could be walking down the stairs, she would hit that tooth and then experience neuralgia-like pain. And what I found was, we handled it on the spot. I was able to identify that aberrant contact, was able to adjust the contact, and she contacted me a week later saying she'd never had a headache again. And you know, I felt really lucky. I mean, at the end of the day, I'd rather be lucky than skillful. But it worked. And with the patient that I described earlier, who's had the full workup for trigeminal neuralgia, it's idiopathic trigeminal neuralgia, and we are seeing we're seeing the slides, we're seeing the occlusal discrepancies. So the last modality that I want to talk about, and I know I'm a little over, is frequency-specific microcurrent. This has been utilized in our practice since 2007. And, you know, microcurrent devices have been around for years. You know, they've been known as alpha-stim and E-stim. What makes frequency-specific microcurrent unique is it delivers frequencies and current in millions of amps. It increases ATP production, and the key principle behind this is that we have two different frequencies that have been identified over the years. I think that started in the early 1900s. It runs two specific channels, delivering a specific frequency for the condition, whether we're talking about inflammation, chronic inflammation, scarring, sclerosis, calcification, a whole host of conditions with respect and with specific frequencies. And then we're having a second frequency run for a specific tissue. We're talking about artery, vein, muscle, nerve. It's quite an extensive list. Important to understanding FSM is this concept of resonance, right? Resonance is illustrated when a singer hits a note, a certain pitch, it's held for a period of time, and it will break the lead glass. The frequencies appear to change cell membrane protein configuration and cell function electromagnetically with this specific frequency signal. So it's biologic resonance. The other hypothesis, or actually the way we are now beginning to understand, because our understanding of how this modality works has really has morphed and changed over the years as we have a better understanding of biochemistry, is that we believe that it actually affects cell signaling. And so for me, where most of my orofacial pain colleagues are treating trigger points with injection, I'm triggering trigger points with this, which is much better and much more readily accepted for the patient than you know, putting a needle into these trigger points and injecting them with lidocaine. The other thing that we found is that these patients also, we were using it with central sensitization. So there's a number of papers published in the literature, including a blinded control study on delayed onset muscle soreness. The 4 papers that I've included here this is the first paper that was published by Dr. McMakin. This modality was developed by Dr. Carolyn McMakin, and it's entitled Microcurrent Treatment of Myofascial Pain in the Head and Neck. It had 50 patients with chronic resistant myofascial pain issues, and in this particular paper, in this particular trial, all but one saw a significant and sustained improvement over a period of 2 months. The second paper is a pilot study to determine the efficacy to improve range of motion and pain in post-radiation therapy for cancer. Microcurrent therapy shows promise for improving the range of motion and alleviating other symptoms associated with radiation-induced fibrosis. So again, we're treating these muscles, these fibrosed, hard muscles, with microcurrent and using frequencies for scarring and sclerosis that have a dramatic ability to work on the fascia and to work on the scarred area to alleviate pain. The third paper that I'm presenting is FSM for non-pharmacologic treatment of neuropathic pain. In this particular paper, what they documented was that both chronic pain and range of motion was increased with the use of the frequencies. And the final paper, this paper was published in 2019. Frequency-specific microcurrent is used routinely at the Cleveland Clinic in their physical therapy department. And this case actually describes care using conservative treatment massage and FSM for a 19-month-old boy with a grade 8 left congenital muscular torticollis with fibrotic nodules. And what they found, they used 10 weeks of physical therapy, stretching, and adding in frequency-specific microcurrent from weeks 3 to 10. And what they found is that, this with 19-year-old boy is that he was able to experience full passive cervical rotation and lateral flexion. And it made a significant difference in the treatment of his torticollis. So, you know, excellent outcomes are achieved with conservative care for these patients, and honestly, I don't see how I could live without it. So I took my first training in FSM in 2006, and this was the paper that hooked me. This was a paper that Dr. McMakin had published, and it's cytokine data. This research was done at NIH, National Institutes of Health, and what they found is that with the application of microcurrent, the data showed decrease in levels of IL-1, IL-6, TNF-alpha, substance P. Patients' VAS pain scores were reduced, and there was increases in cortisol and beta endorphins during the treatment. So the effects of FSM is that it decreases real-time inflammation, and that's what this particular study found. And at that point, I had enough functional medicine training to know how important inflammation was. And when I was seeing the effects of FSM with respect to cytokine changes, I knew that it needed to be a modality within our practice. So as we finish up, one thing that we have to remember is we always have to ask our patients about mold exposure, particularly our chronic mold patients. This was a patient who presented a few years ago with severe generalized facial pain, hyperalgesia, and allodynia. It had had a dramatic and sad impact on her life. 6 root canals were performed over a period of 2 years. 6 root canals. I mean, you know, when you talk about when all you have is a hammer, everything's a nail, I don't think there's any better representation than this. So she was treated, and, you know, we've been able to eradicate her pain. The root canals are out, all of them. She's had ceramic implants replaced, but again, it was cranial osteopathy and FSM that in the initial stages downregulated her pain and really made her comfortable. But when we're talking about mold patients and we're talking about chronic pain patients that are experiencing pain in these areas, we always have to ask about mold exposure, always. This was a particularly relevant article for me when I was doing part of our dissertation is an 18-case study, 18 cases. We have to document 18 cases, provide our treatment, and then justify our treatment with the literature. And I had a patient years ago that kept complaining about severe pain that happened to the point she was a really remarkable, wonderful, beautiful young woman. She was about 25 years old. And she would even wear a plug in her nostril. And she would talk about severe pain in this area, debilitating, 10 out of 10 pain. I was working with Dr. Nathan and Jeff Greenfield, who was an osteopath, and he could feel that there was something happening here. We did a CBCT and found a dramatic deviated septum spur that was impinging on this area. And we referred her to, I can't even tell you how many ENTs, and we could not get anybody to treat her. She eventually committed suicide. And that has haunted me over the years, and this was a paper that I found, effectiveness of treatment of rhinogenic headache caused by intranatal contact. This research was done in Europe, and what they found was that surgery gave a statistically significant reduction in the intensity and frequency of pain when these areas were treated. So it's important to know that our patients who are complaining about pain in this area, we've got to look at the sinus, and we've got to do our CBCT, because for years, conventional thought has been that these deviated septums, these concha bullosas, these turbinates, that when we were seeing anatomical abnormalities there, that they really had no clinical relevance. And this paper was really, really hit home that we now need to pay attention to these in our pain patients. So how did this patient resolve? I ordered a CBCT, and as you can see, her sinus is an absolute mess. When I looked at earlier CBCTs, there were earlier ones that had been done years before, nowhere near as much sinus inflammation as this. But you can see this woman has an intranasal bone spur, and she has a turbinate that is impinging on the preventing drainage of her sinus and contributing to that sinus inflammation. So I don't want to disparage and say that, you know, maybe all those root canals and extractions didn't need to be done. I wouldn't presume to second guess after the fact, but you just got to wonder, because the anatomy was always there. And the best news in my practice life is that we finally have an ENT in Sonoma that recognizes the impact of these and is actually going to treat her. So thank you very, very much. I hope this has given you more tools and this to consider and things to think about with respect to our chronic pain patients. And it won't be as devastating when those patients come in, and we'll be able to have, it'll be easier to take care of them. Thank you very much.
All right.